All right, we're at 7 p.m., so we'll get started. Hello, and welcome to the Musella Foundation's Brain Tumor Awareness Month webinar series. Tonight's special guest speaker is Dr. John Bookckvar, a nationally recognized leader in neurosurgery and a true innovator in tackling one of the greatest challenges in brain cancer treatment, overcoming the blood-brain barrier. Dr. Bookckvar is the Vice Chair of Neurosurgery and Director of the Brain Tumor Center at Lenox Hill Hospital and also serves on the Musella Foundation's Medical Advisory Board. Dr. Bookckvar, thank you for joining us. I will turn it over to you.
Thank you, Vanessa, and thank you, Al, for the opportunity to speak to you tonight. My relationship with Al and the Musella Foundation goes back almost 15 years now, and I'll draw a little attention to some of our collaborations, but I just want to thank you again for your just absolute incredible support of our patients and our caregivers and advocating on our behalf in overcoming some of the greatest challenges that healthcare professionals have to deal with. I'm going to start the talk just with a little introduction about me, so you get a color for how I got to where I am and how that's guided my career. So here's a little slide of my history. I work at Lenox Hill Hospital now, part of the state's largest healthcare provider, Northwell Health. I'm an identical twin here, born at Long Island Jewish Hospital, which is now part of Northwell Health. My father, Billy, was a large influence in my life, obviously, as a surgeon. He worked at another Northwell Hospital, Franklin General, which is now called uh, Valley Stream Hospital, Long Island Jewish. And you can see my brother and I doing an internship in college. My brother is a sort of a story of nature versus nurture. I went into medicine and my brother went into law. But importantly, I was mentored by Kevin Tracy one summer while I was in medical school. And Kevin Tracy now is the CEO and president of the Feinstein Institutes for Medical Research, that is Northwell Health's main research arm, along with Cold Spring Harbor Laboratories. And so that relationship, which started in 1997, really has allowed me to push really the frontiers because Kevin, whose mother died of glioblastoma when he was only 5 years old, has been a huge advocate for making Northwell Health and particularly Lenox Hill Hospital one of the nation's, if not the number one research mecca for glioblastoma and other malignant brain tumors. So when David Langer, who was my chief resident at Penn in neurosurgery, called me to ask me if I wanted to help him build a new department at Lenox Hill Hospital with Kevin's backing and David's leadership and mentorship, we now have created now 11-year-old brain tumor center at Lenox Hill Hospital. And obviously, we're quite proud of what we built. I'll talk a little bit about why I think it's one of the most unique and special places. And with our colleagues, which we have terrific colleagues at other institutions in New York and elsewhere, we're really able to do some novel things in brain cancer research. And of course, this has been highlighted on 2 and soon to be 3 Netflix shows. So just a little bit about the research that we do at Lenox. As many of you know, enrolling in a clinical trial is perhaps the best thing you can do for any human disease. The data shows that those patients who enroll in a clinical trial outperform those who don't enroll in a clinical trial, even if those patients get a placebo or a control arm. So just the mere signing of a consent form improves your chances. Unfortunately, the national average for glioblastoma enrollment in clinical trials is only 5%, but at Lenox Hill Hospital, 70% of our patients enroll in clinical trials. We enrolled 123 patients last year, which was a 105 increase from the year before. And so that's how busy we are enrolling our patients in clinical trials. I think that is more patients than all other New York programs combined. We have 34 human clinical trials, and a big shout out goes to Tamika Wong, who has just been promoted to AVP of Research for the Western region of Northwell Health. But all of our faculty, and we're now about 55 neurosurgeons throughout the Northwell Health system, 12 of which are full-time at Lenox Hill Hospital. And I won't bore you, but we've become the epicenter for industry when it comes to new clinical trials in the brain tumor space. So I want to touch a little bit, and then I'll just talk a little bit about the research and then open it up for questions, just so I know it's late, it doesn't get boring. But I'm going to talk to you a little bit about our relationship with Cold Spring Harbor Laboratories, and as I mentioned, with Kevin Tracy's Feinstein Institutes for Medical Research. Cold Spring Harbor Laboratories, home to 8 Nobel laureates on the North Shore of Long Island, and it is the world's #1 cancer research laboratory. So now all of my tumors get analyzed at Cold Spring Harbor, even though they have to travel down the Long Island Expressway. The specimens get there and they get grown. I'm going to talk to you how we became the world leader in a novel drug delivery mechanism called intra-arterial drug delivery, which allows us to break down the blood-brain barrier selectively without hurting the patient and then deliver high doses of drugs into the area of interest. We've become an international leader on using autologous tissue flaps to bypass the blood-brain barrier. And I'll end just talking about our office-based blood-brain barrier disruption trial. And of course, I'll invite you to 2 upcoming events, both of which are on June 5th, and then I'll take some questions. This is blood-brain barrier disruption using a microcatheter. So when we use these microcatheters, we actually can slide these microcatheters deep into the arterial tree in the brain. We actually puncture the groin, which is what you see here, and we slide these catheters all the way into the brain, and I'll show you a video of that. And we can target areas of the brain, give high dose of drug, and then selectively perfuse that area with chemotherapy of our choice. Here you can see the microcatheterization in the angio suite. You can see the catheter being threaded quickly. This happens within seconds, all the way through the artery, which you can see here in white. It's a hair follicle sized microcatheter, and they can turn these sharp corners and really penetrate into these really selective areas. And then we can give drug just to that area that artery supplies. This is called super selective intra-arterial drug delivery, and it has allowed us to do some really interesting treatments. Here's a snapshot of one case that I did. We call this a sagittal MRI on the right, where you can see my resection cavity where the yellow arrow is. And on the left, you can see the microcatheter being threaded through the patient's arteries, and you see a perfusion, if you will, of the area surrounding that resection cavity. So only that part of the brain is getting blood-brain barrier disruption with the drug of choice. And we've started to look at several drugs, but the lead candidate is a drug that many of you may be familiar with, which is called bevacizumab or Avastin. Avastin is a very interesting drug. It targets VEGF-A, which is a growth factor that tumors need. And we've seen with preclinical modeling, that means in modeling in animals, that if you give high dose of this drug intra-arterially, you're going to get a better response to tumor cell death than if you gave it intravenously. So I'm just going to repeat that. If you give this drug intra-arterially, which gets you a higher dose, you're going to be more effective at killing tumor cells than if you just gave it every other week intravenously. And we published phase 1, phase 2 trials, and now we're leading a randomized phase 3 trial where we're comparing standard of care, which is called STOOP protocol, which is radiation and chemotherapy, and we're comparing it to that standard of care plus our intra-arterial Avastin. And as many of you know, phase 3 trials are often randomized, and our trial is randomized 2-to-1, meaning that 2 out of 3 patients will get the additional intra-arterial treatment, and 1 out of 3 will just get standard of care. And the data up to now is really significant. We published this last year. 1/3 of our patients are living 3 years or longer, and 17% of our patients are living 5 years or longer. So over 33% of our patients are living 3 years or longer, and about 17% of our patients are living 5 years or longer. That's the data from our phase 3 trial. So that's pretty exciting in the world of glioblastoma. We've also done this in children. My colleagues, after I moved over from Cornell to Lenox, my colleagues Jeff Greenfield and Jared Notman did a similar trial in children. So we're not just looking at glioblastoma or high-grade gliomas, we're looking at diffuse pontine gliomas, and that is actually a perfect indication for intra-arterial chemotherapy. We're only opening our pediatric intensive care unit because we have a children's hospital on Long Island. Lenox has not been a pediatric facility, but we will be opening up a new intensive care unit, so we'll be able to do this as well at Lenox Hill. And finally, we don't just focus on one drug. We've looked at cetuximab, which is a monoclonal antibody to EGFR. EGFR is a known protein that sits on the surface of many uh, types of cancers, particularly glioblastoma. So we're looking at this drug in combination with other drugs and also for other types of diseases. And recently, one of my colleagues just published our series. To date, we have the largest series in the nation and the world right now in intra-arterial drug delivery with over 70 patients treated. And again, we've done this for recurrent glioblastoma, newly diagnosed glioblastoma, both bevacizumab and cetuximab being the drugs of choice. So this is a really exciting avenue to exploit because our catheter technologies are improving and the ability to selectively and safely target certain areas of the brain while excluding other areas is really tantalizing when it comes to bypassing the blood-brain barrier. So much so that Boston Scientific came to me and, given our intra-arterial expertise, asked me if I was interested in trying Y90 as a cancer treatment. Yttrium-90 is used in hepatic or liver metastasis and liver cancers. Yttrium-90 is what's called radioembolization, and it's basically a radioactive isotope that once it's deployed in the liver, it releases radiation from the inside. So they asked if we can do this in glioblastoma. And sure enough, we are now one of three sites, us, Roger Stoop at Northwestern, and UCSF are the three sites that are looking at yttrium-90 radioembolization as a new treatment for brain tumors. This is Yafel Cerule, who is our endovascular neurosurgeon running this trial. So again, using these techniques where we selectively can now give things safely from the inside out, spare the patient external beam reirradiation, which obviously causes hair loss and other wound-related issues. These are the exciting intra-arterial techniques that are expanding and coming down the pike. Here's another example of that TheraSphere. You can see how small these are. They're smaller than the human hair. And again, we are taking these microspheres. You can see in the bottom red image, the little blue dots are the radioembolization. You deploy them intra-arterially. They lock in the microcapillaries, and they give their targeted radiation just to the tumor bed. Here you can see one of our patients where we actually look how selective the intra-arterial deployment of radioembolization is. We just got the tumor. So there's no other area that's getting the radioembolization. This is a real patient. So this is really exciting for us. The different colors are the different isodense lines. But again, instead of external beam radiation, this is actually radiation from the inside out using yttrium-90. Just to let you know that Northwell, because we're such a lead in intra-arterial drug delivery, we were invited to do the brain race a couple years back, and we started a company called Entertroy Bio, whose mission is to disrupt the blood-brain barrier. We made this blood-brain barrier permeability kit, and we won something called the brain race. So we do have a lot of kits in the hospital, but there's never been a kit that actually has been used to overcome the blood-brain barrier. So we, with our Feinstein colleagues who developed macrophage inhibitory factor that can open the blood-brain barrier transiently, have started a company to exploit this unmet need for patients. So that's sort of the intra-arterial story. I'm going to move over to some other mechanisms to overcome the blood-brain barrier. The first one is something called using autologous tissue flaps to bypass the blood-brain barrier. So this is a schematic of a human where we all have something under our scalp called pericranium. And pericranium is actually an external supply of tissue, meaning that it does not have a blood-brain barrier. The only thing that has a blood-brain barrier are the vessels in the brain. So I hypothesized that perhaps we can take this extra under the scalp source. Actually, when I take out brain tumors, I can then deploy and put this tissue flap in the surgical cavity, and all the blood vessels in that flap lack a blood-brain barrier. Here's kind of a grotesque picture of it, but this is what I sent to the FDA. So I take out the tumor. You can see a hole in the brain where the tumor was. Then I have this vascular pedicle, and I want you to understand that every blood vessel in that vascular pedicle does not have a blood-brain barrier because it's outside the brain. We then rotate it into the brain, glue it to the surface of the brain, and that anastomosis, or that seal then will allow us to have a pedicle that we can deliver chemotherapy with, and new blood vessels will lack a blood-brain barrier. So we call this a pericranial flap or a temporal parietal fascial flap, same sort of name. And we've done this now. We got FDA approval. This is just another picture of it, but I won't bore you with it. But I'm going to show you a video. I'm going to fast forward it. But
This short can be identified.
okay, so I'm about to lift. That's my pericranial flap. Let's go back a little bit.
Was rotated into
So
the
there's my
field to assess
pericranial
fit.
flap that has extracranial blood supply. It's got a little
Operators
hole in the
assess fit of the
center, but that's
flap
okay.
to
I did a
ensure there
temporal
will be
lobectomy,
minimal
meaning I
expansion.
took out the temporal lobe. There's my flap. That all those blood vessels that are pulsating don't have a
Preliminary
blood-brain
fitting is
barrier,
made,
but all the
and
blood
potential
vessels in the
attack
brain are
endpoints
going to have a
can be
blood-brain
identified.
barrier. So tumors recur next to the site where they were removed. So I'm placing this pedicle flap in a place next to where the tumor is going to recur. Why is that important? One, we can get chemotherapy right into that area. And two, lymphocytes or tumor cells tumor immune cells can actually survey this area and try to prevent recurrence. So that's called our temporal parietal fascial flap. So again, going and doing an investigator-initiated trial is not easy. We have to go through the FDA, IRB, get approval. We just published this on the cover of the Journal of Neuro-Oncology last year. The FDA allowed me to do this in 12 patients. And it's not only safe, our data is quite good when it comes to overall survival. 8 out of 12 of our patients are alive, 2 years are out. Our longest surviving patient is 6 years. So we moved over to another source of autologous tissue called omentum. Omentum is the belly fat that surrounds your organs in your belly. And if you take that tissue out and plop it on the brain, guess what happens? Blood vessels form. Guess what? Those blood vessels don't have a blood-brain barrier. So the FDA allowed me to take this tissue and actually implant it in the human brain as another mechanism to bypass the blood-brain barrier. And all of these trials are done with really all of these institutions. Northwell is a very large health system, but it's actually beautifully integrated. Our medical school, the hospital systems, our laboratories really allow for us to do some really unique things. And finally, I'm just going to touch on ultrasound. Ultrasound sort of was the hot thing in 2024. Many of you know, ultrasound has been now being used to treat Alzheimer's disease. In fact, a big paper last year showed that if you ultrasound one half of an Alzheimer's patient and give Definity microbubbles intravenously, that would open the blood-brain barrier, and then you can give drugs to help that patient. So this was published. This is being done. So we are going to exploit the use of ultrasound. We have a novel implant called a longevity clear fit implant that we can actually attach to the skull after we do surgery on a patient. Instead of giving them their full skull back, we give them a ultrasound permeable implant. And then I can ultrasound right through their scalp at the bedside in the hospital or in the office and actually open the blood-brain barrier with ultrasound. So here's a schematic of that. You can see the ultrasound probe going through a blue little disc, and that's just giving us an image. But then you move over to the other side, that focused ultrasound, FUS, can actually, in the presence of circulating microbubbles, transiently open the blood-brain barrier. So just to explain, ultrasound plus microbubbles plus drug of choice can actually improve getting the drug into the human brain. So we are on the last committee, our IRB. We've already passed through the FDA first committee of Northwell, second committee called the Protocol Review Committee, and now we're in the IRB for this trial, which should be open by our gala, which is June 5th, where we're going to use these Definity microbubbles in conjunction with these ClearFit ultrasound permeable implants to give patients oral temozolomide. Here's an example. I took out this patient's left temporal brain tumor. On the right, there's a yellow arrow that's pointing to my ClearFit implant, which is in the center of a craniotomy replacement. And again, this is what it looks like when I ultrasound at the bedside. On the left is a CAT scan. I got to wheel the patient down. I got to expose them to radiation and get that image. But I can do this at the bedside. I get the same image. There are the ventricles. It's a beautiful image. It's cheap. It's quick. And it's useful if we're trying to open the blood-brain barrier. So here, a patient allowed me to use her image. I'm actually ultrasounding. Actually, I'm not, but my physician assistant, Arthur, is an expert. She's actually putting the ultrasound in the office through a clear fit implant that you can't see because her hair and her scalp has covered it. And the idea would be when she's ready to take her Temodar, which is 5 days on, 23 days off, every single one of those days, she's going to get ultrasound through the implant to open her blood-brain barrier. So that's just ultrasound. And finally, we have with Cold Spring Harbor our development of our glioblastoma organoids, which is our application to personalized therapy. So, for example, tomorrow I'm taking a specimen, a courier picks it up, delivers it to Cold Spring Harbor, where they grow organoids. Organoids are like three-dimensional reconstructions of a patient's brain tumor, and then they can plate it on 284 well plates and screen for any chemotherapy they want. This can be done within 2 weeks. You make an organoid, and a couple of weeks after that, you can make a xenograft. So it's really the way for us to quickly understand if a patient's going to respond to certain therapies. So that's just what we are doing. Obviously, we're really excited about our intra-arterial drug delivery, our surgical tissue flaps, our ultrasound-mediated blood-brain barrier disruption, and our personal organoids. I just want to also tell you that almost a decade after Al and I started at Cornell, we started something called the Brain Tumor Biotech Summit, where we interface with neuro-oncology, biotech, small pharma, large pharma, and investors. We started in 2012, and it's just been a great collaboration. Again, it's happening this year. This is our first year, and Patrick Kennedy, whose father died of a glioblastoma, was our special guest. And again, this year, June 5th, mark your calendars if you want. This year, it's going to be from 8 to 2, and it's free. It's free for all participants. We tend to highlight patient caregivers, investors, and of course, students and otherwise. So again, this year, the summit is June 5th, Lenox Hill Hospital. It's actually 8 to 2 because we have to get ready for our brain tumor gala. We have a large gala, which is a huge way for us to raise awareness and really pivotal research funding for all of these clinical trials. And that also is at night of June 5th as well. So if you have people who are interested and want to participate, we'd love to have them. And if you want to participate, please let me know. And of course, we're starting to film again for another season of our Netflix show, which really highlights our battle against glioblastoma. So Vanessa and Al, thank you again for the opportunity to talk.
Yeah, thank you. That was a lot of great information. And we do have some questions if you have some time. So you mentioned several clinical trials, and I know you have a lot going on. Are all of the ones you talked about today, are those currently recruiting?
All of them are recruiting.
Okay, and you have so many great trials. How do you choose which trial a patient goes into?
First of all, I'm sorry if there's noise in the background. My daughter Ivy just got back from college, so I hear a lot of.
Worries.
It's a good question. So we tend to, we don't want to pillage from our other trials, but we actually design trials for unmet needs. And every trial has a niche that it fulfills. For example, our intra-arterial Avastin trial has no age cutoff. Vanessa, you may know that a lot of clinical trials cut off participation at 65. Well, I got to tell you, I got a lot of 75, 80-year-old men and women who are in excellent shape and deserve a good clinical trial, and yet they're excluded because of age. In fact, I just enrolled a 75-year-old from New Jersey yesterday, and that's the beauty of running first of all, I have no financial interest also in any of my trials. I don't get paid a cent. I have no stock options. I go nothing. And as a patient, that probably is the first question you should ask your provider. Hey, by the way, are you involved in this trial in any way financially? And see how they respond. We have no financial interest. We cater our trials to different kind of niches. Some are newly diagnosed, some are recurrent, some are for patients who've had radiation and chemotherapy already, some are before surgery, some involve an operation, some don't. So some patients are sicker and won't tolerate an operation, but we have something for those that don't tolerate the operation. So, this disease keeps me up at night, and we have a clinical trial for literally every single step of the way throughout the disease. and for really every person.
I really love to hear that. We actually did a webinar last night on finding clinical trials, and we talked about the challenges of narrow inclusion criteria
Yeah.
and how hard that can be. Um, I also thought while you're speaking, one of the things I like about Northwell is they do have what looks to be a lot of investigator-initiated trials versus industry-sponsored,
Yep.
and I think that's important for people to pay attention to as well.
That's exactly right. And I just want to harp on that. I was very happy at New York Presbyterian. Don't get me wrong. I'm not going to badmouth Cornell. And Penn, I was only at Penn and Cornell. They're sort of old, stodgy Ivy League towers, right? But they are very risk averse. Now, I'm not a cowboy, but I know in this disease we got to take some risk. And if you're going to wait around for the next industry-sponsored vaccine that needs less than 1 centimeter of residual enhancing disease to enroll, you're going to be excluding 90% of our population. So we have to be thinking about it. There are a lot of smart neurosurgeons out there, neuro-oncologists who are coming up with really, in fact, I just spoke to one of my colleagues in New Jersey, and I asked her about the Mariposa trial. I don't know if you know this, but Mariposa is the trial for lung cancer, EGFR positive lung cancer. So a great trial came out for EGFR positive lung cancer. So I said, well, why are we not using this in glioblastoma? And she said, I'm writing the protocol for using this in glioblastoma. Now that's the thinking we need to have. And I appreciate, but it takes work. People people always come to me and they say, John, what about this idea? I say, great, just write it. Just
Yeah,
write it.
it takes
Stop
work
telling,
and money.
stop telling me ideas. Put it, execute. And that's hard. It's hard in this day and age to write. People are writing NIH grants. I tend to just write human clinical trials. I get an idea in the middle of the night and I start writing.
Okay. Specific to the super selective intra-arterial delivery trials, you mentioned that the technologies are improving. Are there specific technologies or medical devices that have enabled these types of trials?
Oh yeah, the microcatheterization. So just to give you an idea, in the 90s, they were doing intra-arterial drug delivery in the carotid artery. So what happened? They were very slow and big and sluggish catheters. It used to take 3 days. The patient was come to the hospital for 3 days, and they would give intra-arterial drug delivery in the carotid artery. So you can imagine what happened. A lot of the drug went to the retinal artery, so they blinded a lot of people, and they basically gave it to the entire hemisphere because it was in the carotid. Now these endovascular neurosurgeons are so agile and these catheters are so bendable and they're different sizes and they're different fluidities, and I can't get a cup of coffee before they're like, John, we're ready. What are we giving? So just like your iPhone has gotten better every 6 months or 12 months, the optics are better, the navigation tools are better, the metals are better, everything is better.
Okay. And for the current trials, are they giving a single injection or are there multiple?
They're multiple. All of them are multiple. So you may say, well, how often? They're basically once every 3 months. So I wrote a paper in 2011 showing the cost effectiveness of intra-arterial drug delivery. And actually, some of the medical the companies don't like it because I showed that giving one drug every 3 months intra-arterially is much more effective than giving the same drug intravenously every 2 weeks. And Vanessa, do you know what hospitals charge for IV bevacizumab to an insurance provider?
I don't want to know.
It's $22,000 every 2 weeks, minimum. And so it just is kind of outrageous. And so high dose intraarterial drug delivery is a way to get a high dose to the only place. And by the way, if you put an IV in and you give IV Bev, 20% of it goes to the brain. The other 80% of it's going to your body. So what good is that?
Yeah. For someone that wouldn't qualify for those intra-arterial delivery trials, would it be possible to get it outside of trial?
So I have been very strict with off-label stuff. And as an investigator-initiated trialist, I don't want anything off-label. That's just the way I was raised. I'm sort of a very by-the-book person. Um, so the answer is it will take, but I had a patient who I felt really needed intra-arterial delivery. And for whatever reason, I can't remember, there was one exclusion and I couldn't, so I treated him off. Well, So the answer is I didn't treat him off protocol. I don't know if you know of the FDA Project Facilitate. So
Uh,
Project Facilitate is a way you can go to the FDA and ask for an N of one clinical trial. So I was able to, because he didn't qualify for my trial, and I can't remember why he was excluded. It could be like he had a slightly elevated liver enzyme from a prior history of hepatitis, like something totally irrelevant to our trial. So you can actually call Project Facilitate. A human being usually picks up the phone, or at least they did, and you can get an N of one trial for any drug. Let's say I want to use osimertinib for glioblastoma. I want to give intra-arterial. You can actually get FDA approval for the use of that drug. And you may say, well, why is that important? To me, it just gives me the backing. God forbid there's a complication. And I never want to have a complication off label. Now, doctors do it all the time. You're allowed to use whatever you want. But I need to obviously rest comfortably at night knowing that I'm doing the right thing. It's safe. We're following protocol and we're contributing to meaningful research. If you're doing things off label, that person is not a data point to learn anything from.
okay. I think you already touched on this, but I'm going to ask it the way that the participant asked it. Can you join a trial if you've already had standard of care?
Absolutely. 1000%. I
Okay.
mean, there is never a time where you can't join a trial. There may be a washout period. There may be a time where you have to wash out whatever treatment you had. Sometimes my washout is 2 weeks. Sometimes it's 4 weeks. I sometimes have washout for prior chemotherapy. Sometimes I have washouts for prior radiation surgery. You can always try. And if you can't join a trial, at least be vetted for one. We have nurse practitioners and we get calls every single day. We get online requests, social media requests, Poland, Czechoslovakia, whatever it is. There's somebody always asking, am I a candidate for, and we spend a lot of time making sure we offer them if they're a candidate, at least we screen them.
Okay. And in GBM, one of our things we come up against is for those patients that are past the newly diagnosed stage, but they're not yet to the recurrent stage, they're kind of in no man's land. Do you have anything for them?
So here's my philosophy. The answer is yes. So I think you're saying they're done with standard of care, but they haven't progressed. Is that what I'm
Correct.
hearing?
Yeah.
So this is where we use alternative therapies, or I would say repurposed drugs. So
Okay.
when I have a patient that is successful in the newly diagnosed, either clinical trial or standard of care, and they haven't progressed and they're kind of itching for something, that's where I bring in metformin, simvastatin, fluoxetine, low dose naltrexone, maybe ivermectin, maybe fenbendazole. We bring in those slowly. We have a nurse practitioner who's just dedicated to repurposing of those type of drugs.
Do you do cusp 9? Have you heard of
Yeah.
cusp 9?
Well, I was on that paper of cusp 9. And so this is my modern day version of cusp 9. I start with really the core four, which is metformin, simvastatin, fluoxetine, and valganciclovir. I start with those four. Then, and the patients tolerate them, there can be some side effects. We move on to other things, which can be curcumin, low dose naltrexone, like I said, ivermectin, chloroquine, fenbendazole, mebendazole. Those are kind of the top 10.
Okay.
But I listen to my patients. If patients come to me, I say, show me the data. If it's something that's interesting, great. What I don't love, are unregulated things so a lot of the vitamins and non-FDA regulated stuff, it's a little harder. And of course, medical marijuana we believe in and we bring into our patients. So we encourage them to enlist in the registry. We'll send them to some dispensaries. I have a patient who I call my medical marijuana guru. He
Uh,
basically can tell any patient like whether you need sleep, if it's for seizure, if it's for anxiety, if it's for this, and he'll come up with a concoction and tell you where to get it. And I think that's sort of the window where we use those things because if you put all those drugs in animal models of glioblastoma, guess what? They work better than Temodar.
yeah. Yeah. I've been following, I'm sure you have too, the
Yeah.
Sativex, or they call it Nabiximols trial
Mhm.
in the UK for the cannabinoids. Okay. And I had another question. Somebody said they didn't find your trials when they were looking personally. So I guess the question is, how do patients find your trials? How are patients coming to you? Is it patients that are already at your center? Do you work with the nurse navigators? Like, we have
Well,
a
I would ask that patient back, what were you looking at? If you were on clinicaltrials.gov, you must have seen them.
Okay. I think this particular person just learned about clinicaltrials.gov on yesterday's webinar.
Oh,
So
well,
we're
the answer
trying
is,
to,
look, what's interesting, and we should have a discussion, Al, about search engine optimization. I mean, so clinicaltrials.gov is sort of the repository for clinical trials, at least that have gone through the rigmarole of getting listed. So that's obviously where we get a lot of patients. Google now, and of course, I had a patient come to me, Vanessa, this is a true story. She walked into my office. She had a chat GPT printout of me versus somebody at Columbia University, and she read the differences from ChatGPT. So people are getting information now in different ways. I think obviously we use search engine optimization to try to get the word out, to try to reach. We use foundations, whether it's Musella, whether it's Gamonglio, whether it's all the great foundations. I'm going to an ABTA event on Saturday. We were with Amber Burback today. So we're using all the avenues to get the word out, and of course, patients and caregivers and referring doctors.
okay. And for these trials or other trials you have, because we have some people watching that, their person has DMG or an oligodendroglioma. And so would these things work in those tumors as well?
Yeah,
And
so we have like ONC201 for DMG. We're open at Lennox, which is a specific trial for, it depends what grade oligodendroglioma. So unfortunately, grade 2 oligos, there tend not to be huge amount of clinical trials. Why is that, Vanessa? Because those patients live decades with the current treatment. So many of us are not going to be around, to wait for something that's better than something that works for 2 decades. So it's just one of those things. You're never going to have a trial that has a patient population that still lives, several decades. So, but
Mhm.
for grade 3 and grade 4, depending upon what it is, we do have trials that are catered toward high grade gliomas.
Okay. And how much do the mutations of the tumor affect, how, I guess, the resilience of the blood-brain barrier, for example, in pediatric tumors, like you mentioned, DIPG, DMG, with their particular mutation, the H3K27M, does that affect how hard it is to bypass the blood-brain
No.
barrier? No, not at all.
No, unfortunately or fortunately, the blood-brain barrier is agnostic to those kind of things. And that's why it's so pivotal, because we probably have a lot of drugs that work. I'll give you an example. In lung cancer, osimertinib, which is an EGFR inhibitor, it works in lung cancer to the brain. Now, I'm running around here saying we all have a blood-brain barrier. Why do metastatic lung cancers respond to systemic chemotherapy? And the answer is because the blood-brain barrier is disrupted in brain metastasis, but it's not homogeneously disrupted in primary gliomas or DMGs or DIPGs. So we have a lot of drugs. We just have to open the blood-brain barrier. We just have to open the blood-brain barrier. And if this works in ultrasound and an office-based ultrasound is all you need to do it, then I'm going to retire.
Okay. We have another question. We have a friend in the NYC area with a GBM who recently entered hospice. Her KPS is pretty low. Is there anything that can be done for someone in this situation?
It's tough. That's a tough situation. The one criteria that uniformly we have to stick to is KPS. If a patient is, really 60 or lower, it's very hard because, especially when you're running investigator-initiated trials, those patients can do poorly from any intervention, and you can be at risk for being shut down. And so, unfortunately, if the patient is at the terminal part of their disease, you don't want to subject them to an experimental treatment. It's too hard for them. They're going to be at risk for significant complications, whether it's DVTs, pulmonary embolism, seizure, aspiration pneumonia. Those things are deadly. So some of the hardest part of my job is telling a patient they're not a candidate, and it's time to seriously consider palliation and not to pursue additional care.
Do you think if they tried anything at that point, would sonodynamic therapy just because it's, less
You know,
invasive than,
it really depends upon the situation. The only thing I can tell you, which is interesting, and I'm studying this more and more now, is many brain tumor patients over the course of their, and again, we're seeing more and more long-term survivors. So patients that live 3 years or longer, And the radiation-induced effects, you remember we were radiating these patients based on data from the 1980s and 90s when patients lived 8 to 12 months. So we didn't expect any long-term effects because there was no long-term in these patients. Now these patients are living 3 years or longer, and we're seeing long-term consequences of this radiation. One of those long-term consequences is communicating hydrocephalus, where the ventricles or the fluid-containing spaces in the brain slightly enlarge, and the patients actually become symptomatic. They can't walk as well, they're cognitively slowed, and they're incontinent. And actually shunting those patients, permanently taking the spinal fluid and putting it actually through a device that goes into the belly can relieve some of these symptoms. And I've seen patients decline when their scans look normal, their tumors are gone, and they have hydrocephalus.
Okay. We have actually two questions on, can you speak a little bit to MGMT methylated versus unmethylated? Are any of these trials that you talked about today specifically good trials for unmethylated patients?
So we have one trial, which I did not mention, called CAPTEM, capecitabine and temozolomide. Capecitabine is a drug that's blood-brain barrier permeable, and it's called Xeloda. It's used in metastatic breast cancer. And actually, Robert Fine was head of experimental therapeutics at Columbia, and this was his idea, not mine. My nurse Ashley Ray worked with him, and so he was kind of trialing it at Columbia sporadically. I put it into a formal clinical trial at Lenox, and that combination of capecitabine and temozolomide is to kind of overwhelm the cell. Remember, if you're promoter unmethylated, that means you have more of this repair enzyme, and that means when you give a drug, you're more likely to repair the damage that the temodar is causing, making it less effective. By adding capecitabine, we hope to overcome that repair mechanism and have like a double hit phenomena. And so that trial, in my mind, and whether you use capecitabine or lomustine, there are trials using lomustine and temodar. What is the risk of those trials? That you get bone marrow suppression. You're adding two chemotherapies to one. So again, patient selection is important. Making sure you follow those patients, have a good nurse navigator who's following those white counts. But yes, we do have trials that, like I said, they're very specific. I may say, okay, this patient is done with radiation chemotherapy, the promoter unmethylated, let's hit him with Captan.
Okay. And for the intra-arterial Avastin, do you expect to see still the difference in overall survival between the unmethylated and methylated that we typically see?
The answer is we have that data prospectively, and we will see that.
Okay. Okay. Uh,
Remember, methylation of MGMT is supposed to be predictive of temodar. We're giving a drug that is agnostic again to methylation status. So
yeah.
my hope, Vanessa, is that we don't see a difference in the two.
Okay. And you went through it really quickly, but that longevity clear fit, how is that different from the SonoCloud implant?
A very good question. And we have SoundCloud open, but I couldn't talk about everybody.
Okay.
So when I do a craniotomy, I take off a human skull, I take out the tumor, and I put the human skull back on using titanium mini plates that the patient lives with for life. With the Sonolucent ClearFit implant, I'm going to take off the skull, and in the center of it, I'm going to carve out a little hole and put this window. We call it a window or a fontanelle, like an infant has. Okay. Then I close the scalp, patient goes home. That's for newly diagnosed tumors. When they come back to my office, I can stick an ultrasound on the scalp. I can basically look in through that window. Sonic Cloud is for recurrent patients. So that's for recurrent GBM. My ClearFit implant is for newly diagnosed. The difference with Sonic Cloud, and one of the reasons I'm not a huge fan, is it's randomized, one. So, and I'm not, that's just the way it is. Now they're using a drug also, carboplatin, in the experimental arm, which wouldn't necessarily have been my first choice, but it's fine. And they also have strict criteria. It has to be a very narrow window because the SonoCloud implant is small and it can only ultrasound a narrow part of your cavity. My ClearFit implant can be the entire hemisphere. I showed you that picture. I can ultrasound the whole brain. I can go across the brain. I'm not limited by that implant.
Okay. And then on that exact note, are you familiar with the like either the Senalisence or
Yeah,
for
yep.
the
We have
obvious?
that open. We have that open at our sister site at North Shore.
Wonderful. Okay, and how do those compare?
So first of all, That's a little bit more labor intensive, but it's similar to my idea of being able to do holohemispheric ultrasound. The problem is you have to take 5 ALAs, and which is not a problem, but you also have to go to the center where they have to fit you in basically like a hair salon device, and you have this non-commercially available device. So scaling that is a bit more difficult. Whereas I can open this every hospital in America, and that's going to be a big lift for patients. I mean, for hospitals to buy, you have to buy this device. It's the same reason why the ClearPoint, focused MRI never took off. It was just too expensive for hospitals to buy. My
Yeah.
ultrasound is available in every hospital in America. It could be in rural West Virginia. They can get a clear fit, put it in, and so we can scale this for every patient in America quickly.
Okay. And speaking of access too, with the super selective intra-arterial delivery, how many centers across the country can do that?
Everybody.
Everybody can do that. Okay.
Everyone can do it, but not on my trial. So we have about four. In fact, I just had a call today to onboard Henry Ford in Detroit. We had a call to onboard Robert Wood Johnson in New Jersey. I have a call. We onboarded one site in Texas. We're trying to spread out. You don't want to do too many sites because then the oversight becomes a little bit. You don't want to have centers doing one or two. You want centers to do 5, 6, 10, and
Mhm.
really make sure they're doing it correctly. It is a procedure. It has risk. You don't want to just, you have to be tight.
Sure. Next question. Any thoughts on the personalized peptide vaccines in Germany for GBM?
Oh gosh, I may get crucified online for this, but I'm not a fan of CGAT. Okay. I'm not a fan of CGAT. I think it has robbed many, many poor patients of a lot of cash. I don't trust their data. I don't trust the vaccine. I don't trust what they published. I have absolutely zero confidence in the efficacy of the CGAT vaccine.
Are there any vaccines that you are hopeful for?
Look, I think, we were the lead site for the Mimivax, first in New York to use Mimivax. I've seen a lot of vaccines fail, whether it's Celldex or Antiparsa or, you know, whatever. Again, the brain is an immune privileged organ, right? Lymphocytes don't like going to the brain. So you can vaccinate me all you want. We still have to overcome the blood-brain barrier to allow lymphocytes to get into the brain. So I am inherently skeptical of anybody, and they all have they cherry pick the best patients. So they have no residual or 1 centimeter or less. So yeah, those patients are going to do good whether I tell them to, inject placebo. I mean, look, I don't know if you know this, but there was a CMV trial that failed until they added tetanus toxin. Oh, and the other thing about Mimivax is they're giving a neoadjuvant stimulant. That alone is going to stimulate the immune system. So what is really the reason why patients will improve? Is it the neostimulant or is it the vaccine? In fact, I think it was John Sampson that showed that adding the tetanus toxoid was just enough to make a vaccine. So I tell my patients, go and get as many tetanus shots as you can that your internist will allow you to get. At least get one
Yeah,
shot a
yeah.
year.
My husband actually did a CMV dendritic cell vaccine trial.
Yeah.
But I actually wanted to ask you about that with your flaps, with your pericranial flaps and the omentum. Do you also add an immune modulator
No,
to
but
boost?
I have a slide which I didn't show, so you're ahead of me. So my next slide is adding a PD-1 inhibitor to
Okay.
omentum to release the milky spots that are in omentum to harness that innate immune system. So that's a great idea. Once we get this, I'm putting a foreign substance in the human brain. I got to make sure I don't cause seizure, swelling, and death. So we're not seeing that. The next step would be to release the brakes of the immune system and get some lymphocytes into the brain.
And you just hit on my greatest concern with the Omentum trial is, obviously the blood-brain barrier is there for a reason. How do you know that introducing that
No,
vulnerability there?
here's what we know, and I've removed in two patients omentum a year and a half and 2 years later. And what's really interesting about how the brain treats the omentum, it chews it down slowly over years. And we call that phagocytosis, which guess what, is an immune response. And so in these patients, and we're publishing on this, and we've published previously, that is an immune response that we're getting into the human brain. And by the way, there have been many studies that, there have been studies that have shown using fecal matter, using literally spitting in the brain is enough to elicit an immune response. Remember, our glioblastoma patients are globally and locally immunosuppressed. We have to get them more. And of course, then they're on Decadron, which is the worst thing. So again, we have to find that happy medium, whether it's going to be with immunotherapy, like we're seeing with melanoma, whether it's going to be some of these autologous tissue flaps, ultrasound, we're going to hit at some point and just keep that, long-term survivor curve getting higher and higher.
And how did you choose omentum versus any other vascularized tissue?
So I came up with a pericranial flap literally in the middle of the night while I was doing an emergency surgery. I was holding this piece of pericranium that I was using to repair the dura, and I looked at him like, holy cow, what if I just stuff this in the brain and use it as conduit? And then my partner, Peter Constantino, who uses omentum for a lot of head and neck reconstructions for head and neck cancer, said, John, why don't you look in the data and we can do omentum. So I went in the data, and Mitch Berger from UCSF had done a trial in rabbits using omentum in 1990. So I called Mitch, he was the chair at UCSF. I said, Mitch, what happened? Why'd you quit on the rabbits? He said, John, I just ran out of money and I ran out of time. So here's an animal study using omentum in 1990. And then fast forward to John Bookckvar in 2021 to picking it up. That's the problem with medicine. You had great preclinical data that lay dormant for 30 years. You can imagine all the patients that we lost along the way.
Yeah, absolutely. And we're getting close to the hour, so I think I'm going to narrow it down to just two last questions. I'm really excited about the research with organoids. In your practice, which drugs are you screening on the organoids? How do you choose which drugs to screen? And how do patients get that? Is that done,
Yeah.
outside?
So first of all, we're working now with a company called Kyotech, Kyotec.
Okay, I'm familiar.
Okay. So, in fact, I'm doing my first case with them tomorrow. I just started working with them. So that is one company where they'll make spheres of our specimens and test for temozolomide sensitivity. So it's a quick, we should do live tumor cell assays, but this is actually quick. It's within 2 weeks before you even start Temozar. You'll find out if your cells respond to Temodar. What we do with that data now in organoids, what's really interesting is you can grow an organoid, which is even more three-dimensional than a sphere, and you can actually plate that in and test over 300 chemotherapy agents to see if there's any sort of outliers. Maybe osimertinib works in this patient, maybe it doesn't, maybe one of the lapatinib, whatever it is. So you get an initial screen. But then the value is, then you take that organoid 6 weeks later and you put it into a mouse model, and then you have a beautiful xenograft reconstruction of that patient, and you can trial just about anything. And that's really, and we've done this, and I think Al may have worked with Champions Oncology out of Hopkins a couple of years ago. So the nice thing about this is Cold Spring Harbor has done this with pancreatic cancer, and with our colleagues at Northwell in parallel, we're tackling the two hardest diseases, pancreatic and GBM, and hopefully this, will bear fruit. In fact, with proceeds from our gala last year, funded the development of our personalized organoid treatment trial.
Okay. Yeah. And I think the dream for a lot of patients is to have, AI do screening across hundreds of drugs and combinations of drugs. And glad to see that moving forward. Okay. And then we'll just close with for patients and caregivers that are interested in trials at Lenox Hill, how do they, who's the best contact? Where do they go to see if they'd qualify for any? And
first of all, always you can contact me directly, J Bookckvar at Northwell. I respond to my email like you're texting me. So J Bookckvar at Northwell, Bockckvar. Al has that contact. Social media, Instagram, Twitter, Facebook, I don't care. We're on everything. Google me, reach out to me, and my team will literally get you in ASAP. We have the most incredible, the beauty of building this program from scratch is my nurse practitioner came from Cleveland Clinic. I have two nurses from Columbia. I brought my whole clinical trials office from Cornell. I brought only the best people I've ever been with, and they are absolutely the most available and accessible and able people.
Wonderful. And we'll close on that note. Thank you, Dr. Bookckvar, so much for your time, for this fantastic presentation, for answering all our questions.
And please, registration for our biotech summit. Al, thank you for pushing me to do it again this year. I appreciate it. I could have been lazy, but I wasn't because of you. Registration is free. I waived registration fees this year. Of course, the gala is a bit more expensive. I understand if you can't come, but if you have people who are supporting and want to rally around a patient, we're always willing to make exceptions. It's a really wonderful celebratory night. There's no gala in the country right now that's raising money for brain tumor research. So I had enough of that. So we really rallied the community to help us do that. So if I can be of any help at any time, please don't hesitate.
Thank you so much. That was very informative. One of our best. This biotech conference is my favorite conference of the year. It's the only one that I religiously go to now. And also one thing that wasn't mentioned is we send people to Dr. Bookckvar for surgery. He's like one of the best of the surgeons too. And he didn't mention that, but he
Thanks,
does,
Al.
he does the surgery right. We send a lot of patients down.
Thank you for that.
Sure. And thank you so much. And
All right, go Gray in May.
good, May. Vanessa, you want to mention the next webinar?
Yeah. This webinar
Thank you.
is recorded and will be made available on the Musella Foundation website and on YouTube. And we have several more great webinars coming up throughout the rest of the month. And go check them out. They're all on virtualtrials.org/webinar.
Good night.
Thanks, everyone. Good night.